Is by Paul Fockens. Of course, Paul is very well known. He's the head of a gastroenterology department in MC, Amsterdam Medical Center. He has been the president of EAG, the president of UEG. He's very active, and he will speak about a very important question now. Will interventional EUS replace ERCP? I will say yes.
Thanks, Thierry. Thanks. It's a great honor to give this presentation, especially it's the final presentation. And as Thierry hasn't noted yet, we are now just over 7,000 participants, so I'm very happy. Please show my slides. Chairman, ladies and gentlemen, thank you very much for the invitation to give this presentation entitled Will Interventional EUS Replace ERCP? And I'd like to thank Professor Haru Inoue for inviting me to Endoscopy One, the Tokyo Global Endoscopy Network, which is spanning 3 days, and I think this is the last. These are my disclosures. My talk will be, well, first, why do we want to replace ERCP by interventional EUS? Then I will cover 4 different topics: CBD stones, cholecystitis, biliary drainage, gastric outlet obstruction, and then some conclusions and maybe a small wish list. ERCP was introduced more than 50 years ago, and the first sphincterotomy was done in 1974. So it's really established, although it took quite a while to really replace surgical bile duct exploration. Unfortunately, the adverse events of ERCP are still significant, with a mortality rate of around 1%. And the pancreatitis risk is still too high. Whatever we try to do, non-steroidals, PD stents, the average pancreatitis rate is around 8%. I think interventional EUS can only replace ERCP if it reduces the morbidity and mortality, and of course keeps the same quality and success rate. And I think another important thing, which I also finish with on this presentation, we really need high quality evidence for each indication before we can really say interventional EUS replaces it. And that high quality evidence is not so easy to get. These are quite difficult trials to do, preferred randomized controlled trials. And what you do see in literature, this is just from the past 2 years in really excellent journals, meta-analysis after meta-analysis. But if there's not a lot of basic data, your meta-analysis doesn't really tell you much and doesn't give you level A. Now let's go to the first topic, CBD stones, whether we can do interventional EUS or ERCP. I think CBD stones are still the major indication for ERCPs worldwide. And ERCPs hopefully will only be performed once a stone has been confirmed, because we don't want just a suspicion of a stone for a risky intervention as ERCP is. Now the thing is, of course, that most of these stone patients have a very long life expectancy, so it's different from pancreatic cancer, etc., where we always have to spend a smaller time. The analogy to interventional EUS, especially if you go through the bulb into the bile duct, is a surgical choledochoduodenostomy, but that was abandoned decades ago, especially because of those long-term results. So I think it's highly unlikely at the current time that interventional EUS will replace ERCP for stones. I don't think we should concentrate on that. We first have to prove other things. Cholecystitis is the second topic. Which I think is a very interesting one, because cholecystitis is a highly acute surgical indication normally, both for therapy, just to survive the cholecystitis, and also for secondary prophylaxis by taking the stones and the gallbladder out. Now we see more and more elderly patients at a high surgical risk, which actually are kind of refused by the surgeon in the middle of the night, and they get a percutaneous drain, which is a relatively good solution to control the cholecystitis, but in the long term it's quite troublesome to have a percutaneous drain, and of course the risk of recurrence after removing the drain is quite high. So could EUS guided drainage be as good as or even better than percutaneous? There's this randomized controlled trial, one of the examples of really very good evidence, entitled EUS-guided gallbladder drainage versus percutaneous cholecystostomy, a multi-center controlled superior trial. This is the type of trials we need. And the group from Anthony Teo in Hong Kong randomized 80 patients 80 years old on average, a little bit more even, and they randomized between a PTC or a lumen-opposing metal stent, which was replaced after 4 weeks. And if you look at the technical success of PTC and EUS, they're both actually fine, 99 to 100%. And clinical success is also similar. So I think this is a good start. But then, of course, is it better for the patient? And on this figure, you see the 1 year adverse events. So all these patients were followed for a full year. And then you see in the group of EUS-guided gallbladder drainage, the 1 year adverse events was 25%, where the percutaneous gallbladder drainage had a 1 year adverse events rate of 77%. And the same for the risk of acute cholecystitis, 2% versus 20%, and the necessity of re-intervention in the first 30 days after the initial procedure was 2% versus 30%. So I think here we really have some solid evidence, and my conclusion would be that in elderly patients with acute cholecystitis, a lumen-opposing metal stent drainage is preferred over PTC, of course, when sufficient expertise is available. Topic is biliary drainage. As you know, obstructive jaundice is a common presentation of pancreatobiliary malignancies. And it's also important to state here again that complete staging before drainage is mandatory. We're not treating the jaundice itself, we're trying to treat the disease. So we need a CT scan and or MRI before we consider an ERCP unless there is a cholangitis. ERCP clearly is the current preferred method for drainage and has been compared to different or no drainage, and ERCP still is preferred. EUS-guided extrahepatic drainage seems fairly straightforward with these new developed hot accessories. So what I mean with EUS-guided extrahepatic drainage is actually going from the duodenal bulb or the stomach, the antrum of the stomach, straight into the common bile duct, usually from the bulb. And there, if you have lumen-opposing metal stents again and a hot accessory, it is not all that difficult, although we still lack a lot. Some of the evidence that has been published 2 years ago from the group in Florida, from Rob Halls and Varadarajulo and Yibang, they randomized 67 patients, 33 to EUS bile duct drainage and 34 to ERCP, and they saw technical success which was similar, and adverse events were equal. So this is some evidence that maybe, for instance, in preoperative drainage for pancreatic cancer, you can consider this, although there was no difference in adverse events, which maybe the groups are too small, because I think the adverse events difference will probably mainly come from pancreatitis. This is a Korean study from Pike, similar, a little bit larger, 64 versus 61. Clinical success, 90% to 95%. And the adverse events here were lower for EUS-guided bile duct drainage, but in this study, the pancreatitis rate of the ERCP was higher than we would normally suggest. So, some evidence, but not convincing that we should. Now, this is the, if you look at one of the other studies is from Gauju, and what they looked at is if patients had been treated with EUS bile duct drainage, so they had a hot axial stent, a 6mm stent in 20 patients, they saw no adverse events, and they saw that surgery, a pylorus preserving pancreatic, well, let's say a Whipple's procedure without any problems. Let me show you this video. As you can see here, we're in the bulb. We see the portal vein with the Doppler in it. You see the gallbladder with a stone in it. And then we just scroll back a little bit here. This is the bile duct, straight up, clearly dilated. From the right upper hand corner, you see the hot axial system entering the bile duct, pushing it a little bit into the wall because you need space to develop that first funnel. And as you can see, we're now developing that, and then we can pull that against the wall of the bile duct, and then afterwards release the proximal flange of the stent in the duodenum. As you can see on the ultrasound here, quite nicely visible, but you can even better see it here on the endoscopic image. So what do we have as evidence right now? They seem to be quite similar in adverse events, whether you do an ERCP or you do an EUS-guided bile duct drainage from the duodenal bulb in a dilated common bile duct. It doesn't preclude surgery, but again, we need bigger trials. But it looks quite fair. Then my fourth and last topic is an EUS-guided gastrojejunostomy. This is maybe not really ERCP, it's more duodenal stenting, but this is usually fits under the pancreatibiliary endoscopy, so I thought I would also include it in my presentation. As we know, gastric outlet obstruction is a late complication of pancreaductal adenocarcinoma, duodenal cancer, and gastric cancers. And the fact that if the survival is usually quite poor, but if the survival is more than 3 months, a surgical gastrojejunostomy is preferred over palliation with a duodenal stent. Nevertheless, a surgical gastrojejunostomy has really some risks, and usually patients are admitted relatively long because of gastroparesis following the procedure, and this can take up to weeks. Now, what can we do endoscopically? Let's say if you look at this first drawing, you see a duodenum, you see a stomach, you see the second part of the duodenum, and in black there's something around the duodenum which obstructs it. The first step to do an EUS-guided gastrojejunostomy is putting a feeding tube through that stricture into the horizontal part of the duodenum, close to threads, and fill that with water. And by filling that part of the duodenum with water, you kind of expand it, and you can see it from the stomach with your EUS endoscope. So in that third picture, you see our linear EUS instrument now in the stomach, looking at that area where we just put in 500 or more mLs of water. And we're still flushing with water, and we still see that expanded part. And once you have that good insight, it's actually similar to draining a pancreatic fluid collection with a hot axial stent. Usually done freehand. You just puncture the fluid in the duodenum, and then you place a luminoposometal stent. So ultrasound real time, you see the pancreas, the body of the pancreas here in a patient with duodenal cancer. We push in the scope a little bit, and just beyond the pancreas, you see this is the left kidney, by the way. So we're in the left upper abdomen. We push the scope in a little bit, and you see this fluid-filled structure, which is the small bowel. And you can actually, when we start flushing, as you can see now, you see that this is the small bowel, because that's where the tip of the feeding tube is. Now again, similar, if we have enough expansion, we need about 4 centimeters. We push this hot axial scatter with help of electrocoagulation into the small bowel. And this is a little bit a scary moment, because you only have one chance to do it right. So we're just looking a little bit, pushing a little bit, and finally we decided this is the right way to go, and we push it into the small bowel. You saw there was some resistance. In the past months, we have increased the electrocoagulation current a little bit to make sure we get smoothly into the small bowel. Same as in the common bile duct, we're opening the distal flange first, pulling that then against the wall, making sure that actually it's really snug there. And this is the CT scan of this patient a couple of weeks later, which was made for reasons of her tumor. As you can see, we have a perfect gastrojejunostomy. And this patient finally went to surgery, and we'll show you also the surgical pictures. This is the gastrojejunostomy, stomach on the left side, small bowel on the right side. The surgeon is dissecting it. You start the stent, you see the stent appearing. And finally, this is the stomach with the luminoposometal stent sticking out of it. So this really is a surgical gastrojejunostomy done under EUS guidance. What do we evidence? Again, we have a lot of case series, we have some meta-analysis, and we have this, I thought, interesting study from Boston, where they looked at a consecutive series of 100 patients retrospectively from 24 to 2017. 22 of these patients had undergone an EUS gastroenterostomy, and 78 had under a duodenal stent placed. And if you look at the primary outcome, which is stent failure rate requiring re-intervention, then the EUS gastroenterostomy had 8% versus enteral stents in 32%. Again, it's retrospective, and numbers are relatively small, etc. But if you look at initial clinical success, it's 95% for EUS gastroenterostomy and 76% for enteral stents. And I think we know that if we place duodenal stents, the success rate is relatively low. It's quite often disappointing. The stent seems to be in perfect position, but the patient still cannot eat. So I'm close presentation. The question was, will interventional EUS replace ERCP? I told you for CVD stones, no, I don't think so. For cholestasis in the elderly, I think yes, it should. Biliary drainage, distal malignant obstruction, yes, it could, maybe should, preoperatively and palliative. And for highly malignant obstruction, which I did not cover, I don't think it will quickly do it. There are some indications. And finally, for gastric outlet obstruction, I think, yes, it definitely will change practice here, and we will probably use much fewer duodenal stents and more gastroenterostomies. Please start doing randomized control trial. Please start participating, because that's what we need. And with that, I would like to end my presentation. It was great to be in Tokyo, and I hope that you will all come to Amsterdam in December 16. Thank you very much for your attention.
Thank you, Paul. I think it was a great synthesis and a great overview of all the procedures we can perform using EUS in Europe. A short comment from my side. Of course, we need more studies in order to promote EUS drainage for common bile duct stenosis as the first procedure, first intent procedure. We need probably more data. Just a question about gastroenterostomy. Do you see a role for EUS in bariatric endoscopy?
That's interesting, Thierry. Thanks. There's one quite clear indication. If you did undergo a gastric bypass and you actually lose too much weight, then one of the options could be to put an hot axial stent from the gastric pouch to the gastric remnant and actually kind of resolve the bypass. I think otherwise it will be difficult. For bariatric endoscopy, we would need to make an anastomosis somewhere like halfway the small bowel. And it's difficult to see how we can select that area of the bowel. So we thought about that a lot during the notes period, maybe 10 years ago. What you would need is a reliable way to mark the area of the bowel that you want to get. So I think you need to go out into the peritoneum with your endoscope, then select the bowel and then bring that back up. So I think we're not there yet, not there at all.
Yes, but maybe we could link MRI or CT with EUS, for example, to select yes, the place to puncture. But okay, now I will let the floor to Thomas or to Takao for the last questions and the closing remarks. Thank you very much, Paul.
Sorry. I would like to be less visionary than Thierry. So replacement of ERCP in general is maybe too far away. But wouldn't it be good in the ERCP failure, whatever that is, area? We have the very clumsy enteroscopy procedure. We have PTCD, which is done by some of ourselves. It can be risky, admittedly. So wouldn't be an immediate goal to become #1 in that area?
Yeah, absolutely. I think for failed ERCPs, that is almost a done deal. But one thing what we do need is training, because we are with a relatively small group of people doing it, some people on the side, but we need training and certification in some form. I think if we don't have that, it will not fly. I think what I really personally always find very disappointing, you have a relatively easy procedure in a pancreatic cancer patient, you do the ERCP, and the next morning you're called that the patient was admitted with a quite severe pancreatitis. That happens in more than 5%. So I think in that area for preoperative drainage, I think EUS could very well replace the ERCP, because that rate of pancreatitis is unacceptable.
Yes, I also agree. And Mark, you want to comment?
Yes, it's not so clear for me. I continue to use the RCP for the pancreatic cancer, because the risk of acute pancreatitis is not so high. It's not so high with patients with pancreatic cancer. And the problem, if you fail, even if the technique of choledochorioduodenostomy is more and more safe, if you fail, you face to biliary leakage, which is probably more difficult to solve than an acute pancreatitis, because the acute pancreatitis in patient with pancreatic cancer is, for me, in my experience, I didn't see a very EV acute pancreatitis in patient with pancreatic cancer. But if you fail the puncture of the CBD and if you have a bile leakage, it's for the patient with an operable cancer is probably not the best.
I agree with that, Mark. The problem a little bit is that I think the studies that have been done, like the two I showed, they didn't use a hot system. So I think you would need something like a hot axial system, something lumen opposing, which would probably reduce the risk of failure. But you're completely right. Again, we need to do bigger comparative studies there. Now, of course, many of our patients nowadays get neoadjuvant chemoradiotherapy, mostly chemotherapy. So there you have a little bit more. So some leakage, if you could really quickly resolve it, and the patient will only go to surgery after 3 or 4 months, I think a little bit of leakage would be not too bad.
Thomas or Takao? You want Takao question and then Thomas, you conclude?
Okay, from myself, one question. Paul mentioned gallbladder drainage and the biliary drainage. How about the US-guided pancreatic duct drainage? No future?
Yeah, I think it's interesting, but it's a relatively small indication. And usually, as you know, coming from a country where we do a lot of pancreatitis study comparing with surgery, the surgeons, at least in the Netherlands, are usually superior. But we have some indications, but it's a small niche.
If I can answer, we have more and more indication now because we have more and more patients operated for benign pancreatic lesion like IPMN or neuroendocrine tumor. They develop after 3 or 4 years the stenosis of the virsungo-jejunal or the virsungo-gastric anastomosis. And today we perform quite one pancreatico-gastrostomy every month for this indication. Of course, is the patient are sent in my center for this, but I think we have more indication than for chronic pancreatitis. And the other indication is the chronic pancreatitis when ERCP fail. Mainly in patients with portal hypertension and the difficult patient, not operable patient. But we are more and more indication now.
Okay, that's it.
Thomas, you can.
Okay, so I'm expected to give some conclusion. So I think this was a very nice session. The main message actually is encouraging, and that biliary access by EUS gets into something which seems to become standardized. It's not a crazy thing where everybody does something different. So this I like very much. And then I would like to echo the 3 main points from Paul. And this is data, data, data. So thank you very much.
Okay, thank you. And I think we also can congratulate Aru. More than 7,000 attendees, which this is really fantastic. It's a great course. I suppose they are not only from Japan, probably a lot. We have probably a lot from Europe.
Champagne and fireworks now.
Okay.
Okay, have a nice day. Have a nice day in Europe and have a nice evening in Japan, probably.
Okay. Go to
Bye-bye.